Hi. Today is the second video on medical disorders in pregnancy. Another very important topic, that is thyroid disorders in pregnancy. To introduce myself, I'm Dr. Aishwarya. I'm a consultant gynecologist and fertility specialist practicing in Chennai. Currently, I'm doing private practice, but in all the good institutes. I did my post-graduation in All India Institute of Medical Sciences as an ONG. And then thereafter I was in JUPMA for my senior residency, and then did my FNB in reproductive medicine. Thyroid disorders in pregnancy is very common, very common problem which we deal with in India. That's maybe because there is a lower cutoff and more diagnosis, that's what I feel. However, in the endemic region, the actual thyroid disorders are more. So let's go into the topic and see what the disorders are from the basics, and what are the treatment options available, the management and things, everything. So the anatomy, starting from the very basic anatomy, it's an endocrine gland which is butterfly shaped, bilobed. It secretes T4, T3 and calcitonin, weighs 25 grams. The size is usually larger in females and increases up to 30% in pregnancy. So the thyroid physiology is like, so the hypothalamus secretes the TRH, which goes through the hypophyseal stalk into the pituitary and releases the TSH. TSH goes into the thyroid gland and stimulates it to produce T3 and T4. T4 is the inactive form of thyroid, so it produces reverse T3 and T3, which is the active form of thyroid. Both T4 and T3 exhibit a feedback mechanism, causing negative feedback mechanism on the pituitary and the hypothalamus, and decreases the production of TSH and TRH. So how this thyroid is being formed? So iodine transport it happens. All the raw materials are usually taken inside from the basal membrane. This is the thyroid gland, this is the thyroid follicular epithelial cell, this is the luminal side, and this is the basal side. Okay. So this luminal side, this forms the colloid of the thyroid. Okay. So the iodine is being transported, and then it is bound, it then goes off as iodine I2, and then it is bound to thyroglobulin as monoiodothyronine, diiodothyronine. Okay, oxidation and organification of iodine is performed by this thyroid peroxidase enzyme, and then coupling of MIT and DIT by the thyroid peroxidate happens. So 2 diiodothyronine form the T4, 1 monoiodothyronine and 1 diiodo forms the T3. So that is the mechanism of formation. Then the processed thyroid globulin, again, whenever there is a requirement of T3 and T4, which is the active form, this is being taken from the inside the luminal surface back inside the thyroid epithelial cell, and then it is being processed by the lysosomal degradation and release of this T3, T4 into the blood circulation. So this is very simple, basic physiology. So what happens in pregnancy is that there is an increase in the thyroid binding globulin. So there is an increase in the total T4 levels. That is not going to cause any harm. However, when there is an increase in the HCG hormone, especially in the first trimester, which increases in the 7 to 12 weeks, what happens is, this causes a increase in the free T4 levels, because it's very similar to the free T4 levels. So it will cause a negative feedback mechanism on the TSH. So when there is an increase in the T4, there will be a drop in the TSH levels. Except for the transient increase in the free T4 levels, the levels are essentially unchanged. So that is why there is a lower cutoff for TSH in the, there is an increase which causes an increase. So there is a higher cutoff of TSH in the pregnancy. So this usually returns to normal in the second and third trimester, but it is lower than the non-pregnant women. Okay. So this is a very important physiological change in the pregnancy that you have to know. So in multiple pregnancy, what happens is, because there is more HCG, more increase in the free T4, and it will cause decrease in the TSH levels. So that is what we see as hypothyroid. Okay, so a downward shift in the TSH reference interval is greater in the twin pregnancies and the multiple pregnancies. So pregnancy has a profound impact on the thyroid gland and its function. Okay, so the thyroid gland increases in size by 20 to 40%. The iodine requirement increases by 50% and T3 T4 increases by 50%. Also in pregnancy, increase in the renal iodine excretion and total thyroid binding globulin. All these factors influence thyroid function test in pregnant patients. There is a need for different ranges in the pregnancy also. So up till now, American Thyroid Guideline Association to 2011 guidelines for pregnancy are being followed. Significant clinical and scientific advances have occurred in the field. So there is a requirement of reformulated recommendation. Now we are following the 2017 ATA guidelines all around in all the good centers we are following this only. So what happens is 2014 this was published. Based on this study only this change in the guidelines was required. Okay. What it says is that using a reference range of less than 2.5, 27.8% were subclinical, whereas when you increase the cutoff to 4.87 as upper limit, then only 5.7% were subclinical hypothyroid. So that is why the cutoff of arbitrary cutoff of 4 has been adopted. Okay, further analysis shows that children born to mothers with TSH of 2.5 upper limit have similar mental developmental index and psychomotor developmental index as in the controls. Insufficient evidence for and against the universal screening are there. So, serum TSH is the principal determinant of maternal thyroid status and is used as a guide for treatment and decisions. When possible, population-based, trimester-specific TSH reference ranges should be defined, and if not available, a cutoff of more than 4, which is considered to be hypothyroid, it should be used. In the first trimester, the lower range of the thyroid can be reduced by approximately 0.4, while the upper reference range is reduced by 0.5 to 1 milli international units per liter. Usually, we take the cutoff of 4.